Hello everyone and welcome to our module on intracranial bleeding. The easiest way to understand intracranial bleeding is to think about the fact that bleeding can occur at basically 4 different levels within the skull. If you look at this drawing over here on the right, here we've got the brain tissue itself. And when people bleed into the brain tissue itself, that's called a hemorrhagic stroke. And I talk about hemorrhagic strokes in some of the videos on strokes. Surrounding the brain tissue are the meninges, and the meninges are made up of 3 layers: the dura mater, the arachnoid, and the pia mater. So one place that you can have bleeding is above the pia mater and below the arachnoid, and because this bleeding occurs below the arachnoid, this is called a subarachnoid hemorrhage. The next place you can bleed is above the arachnoid and below the dura mater, and because this bleeding occurs below the dura mater, it's called a subdural hematoma. And then finally, you can bleed on top of the dura mater beneath the skull, and this is called an epidural hematoma. And so we won't talk about hemorrhagic stroke in this video, but we'll go through these 3 causes of intracranial bleeding one at a time. Let's start by talking about a subarachnoid hemorrhage. A subarachnoid hemorrhage is bleeding into the space between the arachnoid and the pia mater. If you look at this drawing in the bottom left side of the screen, we've got the brain tissue here. This is the pia mater shown in pink. This is the arachnoid shown in blue. And between the pia mater and the arachnoid membrane is the subarachnoid space, and that's where major blood vessels run. If one of those blood vessels ruptures, that will cause bleeding into the subarachnoid space, and that's called a subarachnoid hemorrhage. Now, also found in the subarachnoid space is the cerebrospinal fluid, and this is important to know because when there's bleeding into the subarachnoid space, you will find blood in the CSF, and we'll talk about that later for diagnosis of subarachnoid hemorrhage. And the most common cause of a subarachnoid hemorrhage is a ruptured berry aneurysm. A berry aneurysm is shown here in this picture. It gets that name because it looks like a berry. It's a weakening of the vessel wall with abnormal dilation, and when patients develop these and they rupture, that causes bleeding into the subarachnoid space and a subarachnoid hemorrhage. People who have a subarachnoid hemorrhage develop the sudden onset of symptoms, and the usual symptom that they have is headache, and the classic description of the headache is as either the worst headache of my life or a thunderclap headache. If someone says to you in the emergency room, "I'm having the worst headache of my life, it came on suddenly 30 minutes ago," that is a red flag that that person could have a subarachnoid hemorrhage. Patients can have fever. They can also have nuchal rigidity. This is rigidity at the neck. It's a sign that you often see in meningitis, but you can also see it in subarachnoid hemorrhage from irritation of the meninges. Focal deficits like motor weakness of the arms or the legs can occur, but it's very rare. And a little bit under half of patients will lose consciousness from the sudden increase in intracranial pressure that occurs when bleeding occurs into the subarachnoid space. If you think your patient has a subarachnoid hemorrhage, the best initial test is a non-contrast CT scan of the head. This is usually diagnostic in about 95% of cases. If you look at the bottom of the screen, on the right side is a non-contrast head CT from a normal patient. On the left side of the screen is a non-contrast head CT from a patient with a subarachnoid hemorrhage. And you can see this white material here, that's blood filling the subarachnoid space. It's also spreading out between the tissue of the brain. Classic finding of a CT scan in a patient with a subarachnoid hemorrhage. CT scans are much more accurate for diagnosis of subarachnoid hemorrhage the earlier they are done after the onset of symptoms. The highest sensitivity for picking up a subarachnoid hemorrhage is in the first 6 hours. CT scans almost never miss subarachnoid hemorrhages if you are doing the CT scan within the first 6 hours after the patient develops symptoms. Beyond 6 hours, there begin to be changes in the brain, and it's more likely that the CT scan will miss the diagnosis, and that's how many of the 5% of cases are missed by a CT scan. So a non-contrast head CT is the best first test if you think a patient has a subarachnoid hemorrhage. But the most accurate test is a lumbar puncture. Remember what we said before, the CSF runs in the subarachnoid space. So if there is bleeding in the subarachnoid space, you will find blood when you do a lumbar puncture and examine the cerebrospinal fluid. What you see in patients with subarachnoid hemorrhage after a lumbar puncture is a finding called xanthochromia in the CSF. Xanthochromia is a yellow color that the CSF takes on from breakdown of red cells. If you look at this picture on the screen here, CSF should be clear like this tube on the left, but it will look yellow in patients with subarachnoid hemorrhage, and that is xanthochromia. And so a lumbar puncture is useful because it's more accurate and it will pick up the 5% of cases missed by CT scan. What this means is that if you have a high clinical suspicion of subarachnoid hemorrhage but a negative head CT, then you need to do a lumbar puncture to look for xanthochromia. A lumbar puncture can also find white cells and red cells in the cerebrospinal fluid. That's because there's bleeding into the subarachnoid space where the CSF is found. Importantly, however, the ratio of white cells to red cells in a subarachnoid hemorrhage will be 1 to 1,000 or less. This is the normal ratio when blood gets into the CSF. If the ratio is higher than 1 to 1,000, that means the patient has meningitis. Remember that meningitis can have symptoms like fever and headache and nuchal rigidity that can mimic subarachnoid hemorrhage. But in a patient with meningitis, the head CT will not show bleeding, and when you do a lumbar puncture, you will find white cells and red cells, but the ratio will be much higher than 1 to 1,000 because the inflammation from meningitis is driving up the white blood cell count in the CSF. So now let's talk about baryaneurysms, which are the usual cause of a subarachnoid hemorrhage. Most people who have a baryaneurysm are asymptomatic. When they are diagnosed before they rupture, it's usually because a person has a head scan for some other reason like headache. The most common clinical presentation of a baryaneurysm is a subarachnoid hemorrhage, as we just discussed, but rarely the aneurysm can get very big and not rupture, and then it can cause neurologic impairment. And we'll talk about some of the neuro findings in patients who have very large baryaneurysms in a second. Most baryaneurysms, about 85%, occur in the circle of Willis. So let's talk about that now. So shown on the screen is the circle of Willis, and the carotid arteries fill the circle of Willis at these 2 points here and supply blood to the front part of the brain. These arteries here are called the anterior cerebral arteries, and they connect and have this small connection here called the anterior communicating artery, and that is the most common location of a baryaneurysm, at the anterior communicating artery. The circle of Willis also has this section right here on both sides called the posterior communicating artery, and that is the second most common location of a baryaneurysm. And then finally, the third most common location is the middle cerebral artery. Aneurysms here are relatively uncommon. Many patients develop baryaneurysms in isolation without having any other systemic disease, but there are some disorders that are associated with baryaneurysms, and you should know these for your boards. One of the most important is polycystic kidney disease. Patients who have polycystic kidneys have kidneys that look like this shown on the screen here. I talk about polycystic kidney disease in videos in the renal section, but the way that many patients with polycystic kidney disease die is from rupture of a baryaneurysm, and it's high yield to know that. You can also see baryaneurysms in patients with forms of connective tissue diseases like Ehlers-Danlos or Marfan syndrome. And then finally, baryaneurysms are also associated with hypertension and smoking. So let's go back to this picture and talk about what happens when you have a baryaneurysm right here in the anterior communicating artery. That aneurysm is going to enlarge right near the front of the brain, and that's going to cause symptoms. And the common symptoms that an anterior communicating artery aneurysm causes are headache and visual field defects, classically bitemporal hemianopsia. The aneurysm will compress the optic chiasm, and that is going to cause the patient to lose vision on the outside, the temporal portion of both visual fields. The two classic causes of bitemporal hemianopsia are a pituitary tumor or an anterior communicating artery aneurysm. So back to this slide. Now let's talk about what happens if you have a baryaneurysm of the posterior communicating artery. That's going to cause symptoms that are localized to either the left side or the right side of the body. So very large posterior communicating artery aneurysms can cause unilateral headache and eye pain, and these aneurysms classically cause a cranial nerve 3 palsy. In a cranial nerve 3 palsy, the eye is down and out, as shown in this picture on the screen here. There's also ptosis, which is drooping of the eyelid, as shown here. And then finally, the pupil will be dilated and will not react to light. In any patient who has a cranial nerve 3 palsy, one of the most important things you need to do is evaluate the pupil and ask yourself if it's normal or not. If the pupil is normal, that means it's not dilated, and it will also be equal with the pupil on the other side. And if this is the case, we call this the pupil being spared in a cranial nerve 3 palsy. And when the pupil is spared, that's very good news for the patient because that means the lesion is not an aneurysm. If the pupil is involved, meaning there's a dilated pupil like what's shown in this image on the screen, then that means the pupillary constrictors are being compressed, and they are easily compressed in the subarachnoid space, and the thing that usually causes this is a posterior communicating aneurysm. When the pupil is spared, this usually means the patient has a cranial nerve 3 ischemic neuropathy from small vessel disease. This often happens to patients with diabetes. They sometimes have eye pain, and usually the cranial nerve 3 palsy spontaneously resolves. And so this is called the rule of the pupil. And remember that when the pupil is dilated like this, that's bad. That suggests there's an aneurysm. So back to our discussion of subarachnoid hemorrhage, let's talk about treatment. The treatment is usually with endovascular coiling or clipping. These are procedures where a neurosurgeon or a neuroradiologist inserts a catheter and other devices into the vessels in the brain to try and stop the bleeding. And the major problem that occurs in patients with subarachnoid hemorrhage after treatment is that rebleeding is common. And when patients have a rebleeding event, they will develop vasospasm of vessels in the brain. This is triggered by blood, and their neurosymptoms will suddenly get worse. This can happen days after an initial bleed. So when a patient is in a neuro ICU 2 or 3 days after endovascular treatment of a subarachnoid hemorrhage, if that patient develops headache or new neurodeficits, you have to consider that they're having vasospasm, and you have to consider that that is likely from rebleeding. Patients who have had a subarachnoid hemorrhage are often treated with nimodipine, which is a calcium channel blocker. This drug improves the outcome for patients who have subarachnoid hemorrhage. The mechanism is unclear, but it's believed that it may prevent vasospasm and that this overall leads to better outcomes of patients in the neuro ICU after a subarachnoid bleed. Moving on, let's talk about a subdural hematoma. So a subarachnoid hemorrhage was bleeding between the arachnoid and pia mater. Now we're going to move up a level and talk about bleeding beneath the dura, between the dura and the arachnoid. And when that happens, it's called a subdural hematoma. This is a bleeding problem that is usually caused by trauma, and it's usually caused by rupture of bridging veins which run beneath the dura mater. And because it's a venous bleed, not an arterial bleed, the bleeding is usually slow because there's low pressure in the veins, and this leads to a slower onset of symptoms, in contrast to subarachnoid hemorrhage, which comes on abruptly because that's bleeding of an arterial vessel. The risk factors for subdural hematoma are older age, use of alcohol, and being on blood thinners. And because many elderly patients are on blood thinners for atrial fibrillation, this is usually a problem that occurs in older people. This is a picture of my grandmother. She never had a subdural hematoma, but she is in the group that has them commonly. And the reason older patients have subdural hematomas more often is because the brain shrinks as we age. This is called brain atrophy. And this increases the space that those bridging veins have to cross in the skull, and therefore the veins are more vulnerable to rupture. You can also occasionally see subdural hematomas in babies, and when this happens, it's usually evidence of the shaken baby syndrome and child abuse. So as I said before, subdural hematoma usually does not present suddenly. This can happen in rare cases, and these patients present with severe neurologic impairment and coma. Usually these patients have had a very, very large subdural hematoma. More often, it presents slowly over a few days or weeks. This is referred to as a chronic subdural hematoma. These patients complain of a headache. They can develop neurologic impairment like motor weakness or sensory loss, and they can also get tired and somnolent. So the classic history is an older person who had a fall about a week ago and has had a headache ever since then and is now beginning to become less responsive and has neuro impairment. That's a classic description of a patient who had a subdural hematoma. The diagnosis is made by CT scan, just like with subarachnoid hemorrhage, and what you will see is a crescent-shaped area of bleeding near the skull. If you look at this CAT scan on the screen here, this is the subdural hematoma. It's this white crescent-shaped area just beneath the skull on the right side. The treatment of subdural hematoma is either neurosurgery or observation. For most patients who have smaller subdural hematomas, they are just observed over time. However, in rare cases, patients need surgery. This all depends on the size of the hematoma and the severity of the symptoms. Our final cause of intracranial bleeding for this video is epidural hematoma. So if we look at this drawing on the screen here, we talked about how a subarachnoid hemorrhage occurs below the arachnoid and above the pia mater. Then we talked about how a subdural hematoma occurs beneath the dura mater and above the arachnoid. Well, now we're going to move up one more level and we're going to talk about an epidural hematoma, which occurs above the dura mater and below the skull. Epidural hematomas are always traumatic. They're often caused by fracture of the temporal bone. That bone is very close to the middle meningeal artery, and when the middle meningeal artery ruptures, it will bleed into the epidural space. The diagnosis is made by CT scan, just like most forms of intracranial bleeding. And what you will see is blood inside the skull that has a convex shape. I'll show you a picture of that in a minute. And the treatment for epidural hematoma is urgent surgery. This is a high-pressure arterial bleed into the skull, and it has to be operated on right away. These are two CT scans of patients with epidural hematomas, and note that there is a convex shape of the bleed, and the reason it's convex is because it's above the dura mater, and the dura mater is holding the bleed back, and that gives it this sort of stretched convex shape, kind of like fluid filling a balloon. You can see another one here on the right side. You can see that this is very different from the crescent shape of a subdural hematoma. The general symptoms of an epidural hematoma include a headache, which then progresses to drowsiness and loss of consciousness as blood accumulates in the skull and presses on the brain. Classically, when patients lose consciousness from an epidural hematoma, they have a history of what's known as a lucid interval. This refers to a sequence of events that occur after head trauma in patients with an epidural hematoma. So first, the patient will lose consciousness related to a concussion from the initial brain trauma. They will then recover from the concussion and appear to be lucid, but then they will have deterioration due to accumulating blood in the epidural space, and gradually they will lose consciousness again. And this is called a lucid interval, a classic feature of patients with epidural hematoma. And that concludes our module on intracranial bleeding.